Hello.
Recording in progress.
It's a 2-year, 11-month-old female child, second by birth order, born by non-consanguineous marriage, resident of Ghatiperi, Dhenkanal, Odisha, belonging to low socioeconomic status, was brought to us by the mother with the chief complaints of poor weight gain, increased rate of breathing, and vomiting episodes 3 to 4 times since 2 months of age. The history is given by mother and it is reliable. There was a history of one hospital admission at 1 year of age for 10 days requiring oxygen support, nebulization, and IV antibiotics. The child was apparently alright till 1.5 months of age when the mother observed that the child is having hurried breathing throughout the day, which increased after feeding. There were mild subcostal and intercostal retractions present even at rest. Child has poor growth as compared to the elder sibling who is 8 years of age and peers of same age group. Child vomits out 3 to 4 times almost after every feed, small in amount, consisting of undigested food material. There is one episode of hospital admission for pneumonia at 1 year of age for 10 days, for which IV antibiotics and oxygen therapy was given. Child was not on any ventilative support and mother was with the child. The baby is born by a normal vaginal delivery to a 32-year-old mother and 37-year-old father. There was antenatal period was normal, 5 antenatal checkups, no anomaly scan or fetal echocardiogram done. Natal and immediate postnatal period was normal. There was no history of NICU admission. There was no history of cyanosis, excessive sweating, recurrent respiratory tract infections, reduced urination, generalized edema, convulsions, loss of consciousness, and prolonged fever. There is no history of similar illness in the siblings who is 8 years old or sudden death in the family. Developmentally, child walks ups and down the stairs, scribbles, comes when called, and no toilet control is yet achieved. Developmental quotient is 41%. He is moderately developmentally delayed. Immunization is complete for age. Should I summarize?
Yeah, go ahead, please.
A 2-year, 11-month-old female child with poor weight gain and tachypnea, feed regurgitation since 2 months of age with one hospital admission at 1 year of age and moderate developmental delay.
So you have summarized your history that likely that this baby has some congenital heart disease. So likely that you have dated the history till since you have protracted your history since the age of 2 months. So can you give us the reason why instead of the child presenting at almost 3 years of age, we have decided to trace back the history since 2 months of age? Was there a reason for that one, or there was some specific reason for that one?
Because the mother gives the complaints at 2 months of age,
right,
which are continuing till age.
So even the same chief complaint or the same complaint which was there since the age of 2 months has not been mitigated. That means that you mean to say that the problem with which the child started at about 2 months of age is still persistent. That means even if the child has some congenital heart disease, that problem is still persisting, isn't it? Or that same pathophysiology is still working.
Yes.
Fine. So in this case, based upon your history, you have mitigated. You have told that in the history there was one hospital admission at 1 year of age. So what and why was it likely? What was it likely due to?
So the mother says it was due to pneumonia. Child has had respiratory tract infections for which he was given oxygen support and nebulization.
Fine. Do you think that this hospital admission, that is the pneumonia, can be temporarily related to the child's congenital heart disease, or it can happen in any person? In this particular case, the child of 2 years, 11 months, almost 3 years old child, since who has been suffering from the age of 2 months with the feed regurgitation and poor weight and tachypnea, moderate developmental delay, do you think this can be temporarily related?
Yes, sir, because I think that this must. I think this must be I have jotted down my differential diagnosis as a moderate size post tricuspid shunt. So, or a congenital heart disease with increased pulmonary blood flow, for which respiratory tract infection is one of the major sign, but it does not come into the category of recurrent respiratory tract infection because the child had a hospital admission only once in 12 months.
Fine. So what I meant was is there any temporal relationship between the occurrence of respiratory tract infections and some congenital heart disease? Because you have given a beautiful history that the child is having some form of respiratory tract infection, needed one admission. So this is not fitting into the classical thing that the child is having recurrent respiratory tract infection. So according to the IP criteria, what did you call a recurrent respiratory infections, and up to how many infections are allowed or respected in within 1 year to call it as a recurrent respiratory tract infection?
4 to 6 episodes of lower respiratory tract infection, or at least 2 hospital admissions for lower respiratory tract infection in the span of 1 year are considered as recurrent respiratory tract infection.
Okay. The second important thing is you have said moderate developmental delay. So this moderate developmental delay, this one also, would you like to temporarily allocate the congenital heart disease for this developmental delay, or do you think there was some other pathophysiology behind that one? Because there are some congenital heart diseases which will hamper the normal developmental delay. So in this particular case, do you think this was the congenital heart disease was the predominant reason, or there were some other reasons?
So usually we have 2 categories of diseases, that is the cyanotic heart disease and the acyanotic heart diseases. So the acyanotic heart diseases are more of associated with the growth and less of associated with the development. Only when the acyanotic heart disease have a syndromic association, they have developmental delay. But in a cyanotic heart diseases, there is more of a developmental delay, and physical growth is less of hampered.
It more or less it is less hampered, definitely, but the more of this is the psychosomatic development and the meditation, which is more delayed, isn't it? So depending on that one, we have come to the conclusion that this child might have some heart disease. So can you tell me, according to NADA's criteria, do you think that this child really has some heart disease? But going back to the very basics, major symptoms, major and minor criteria had.
So, but major and minor criteria are mostly based on the signs. That is a loud second heart sound, a systolic murmur, which is more than grade 3, a diastolic murmur, which is in all 3 are the major criteria.
Correct. So now that we have not come to the examination part as well, right from the history, we are suspecting that the child has some congenital heart disease. So from now, you can tell the other 4 points which you have already picked it out. That what do you think the kind of heart disease that the child has?
I think the child might have a moderate size post-tricuspid, an admixture lesion with moderate AV valve regurgitation, cardiomyopathy with dysfunction, congenital AV valve regurgitation. I would also like to consider, I have not written it, I would also like to consider alkapine.
Okay, so these are your 4 differential diagnoses after the history part that you have. The first point you have put rightly, that is a moderate size post-tricuspid shunt, admixture lesion with moderate AV valve regurgitation, either with the cardiomyopathy dysfunction or congenital AV valve regurgitation. Now let us go one by one. Why do you think it's a moderate size post-tricuspid shunt? What are the points in favor and what are the points against?
So the history, according to the history given by the mother, child is having silent tachypnea, which is present throughout since 2 months of age. That is the time when the pulmonary vascular resistance falls, and so a post-tricuspid shunt like a VSD or PD or a small EP window will show its signs and symptoms, and also has poor weight gain, which is also a symptom of moderate post-tricuspid of a post-tricuspid shunt. These are the conglomerate symptoms of a congestive heart failure in a child as pulmonary vascular resistance falls.
Fine. So do you think it can, by any chance, can it be a pre-tricuspid shunt, if at all? What are the points against?
So the age of presentation at 2 months of age is...
So the age of presentation at 2 months of age is obviously, it cannot be pre-tricuspid shunt, isn't it? So the other point, which you say that it's a moderate, why do you
weight gain, they and silent tachypnea, they favor admixture lesion with moderate ABPR. Also, as there is no cyanosis which is observed by the mother, that also comes in admixture lesion with increased pulmonary blood. Admixture lesions with increased pulmonary blood flow do not present with any kind of cyanosis. So these are in favor of.
Fine. So you have asked that there is moderate alveolar regurgitation. So admixture lesions with moderate alveolar regurgitation would have had more signs of prominent signs of failure, which the child in question does have. Now, cardiomyopathy with dysfunction, I agree it is one of the differential diagnoses, but probably for this particular child to have cardiomyopathy with dysfunction, that means that the history dating back since 2 months of age, there would have been either there would have been something congenital, or the child must have suffered from some kind of a myocarditis very early in his life, so that the child has the fallout of a cardiomyopathy dysfunction at this age, isn't it? So that there is no particular history that the child had some fever, diarrhea with rash or something like that before the age of 2 months, which can support the diagnosis that the child is having some cardiomyopathy dysfunction. But obviously, it's true that in the third position, down later, you can keep the diagnosis of cardiomyopathy dysfunction. And congenital alveolar regurgitation is quite rare because we won't keep the diagnosis right straight away, but definitely it is one of the diagnoses. One note, someone has written, what about obstructive lesion, progressive cardiac dysfunction? Yes, it can be one of the differential diagnoses, that it can be an obstructive lesion, with the progressive dysfunction. Would you like to elaborate on that one? Can it be some obstructive lesion with this particular type of an history? Can it be some obstructive lesion? For example, there is aortic stenosis, mild to moderate aortic stenosis start with, now that it has become severe, or there was mild coarctation to start with, or there is mild pulmonary stenosis to start with, now that it has become severe. So what are the points in favor and what are the points against this particular diagnosis? Obstructive lesions. Yes, according to this history, it can be. There is some room that there is no cyanosis, but it can be one of the obstructive lesions, which it can put into the differential diagnosis, isn't it? So this is the main three obstructions which you can have, either is aortic stenosis, pulmonary stenosis, most of the left-sided obstructive lesions, which can present with these kind of features. But usually, if they are increasing, they are a bit aggressive in history, and the history won't be dating back from the dating since 2 months of age to the age of 3 months, a little bit protracted time period, I would say, for an obstructive lesion to become more prominent. If an obstructive lesion is becoming prominent, probably the history would have become a little bit shorter, maybe say about 6 months of age, by which the age was mild or moderate to start with and has become severe, isn't it? So this point well taken. It can be a history of an obstructive lesion, but probably the history would be slightly more shorter for the child to have presented. Go ahead, please. Going to the examination part.
On anthropometric measurements, child weighs 9.8 kg, height 83 centimeter, and head circumference 43 centimeter. All are less than third centile. There is severe failure to thrive. Pallor is present. No cyanosis, no edema, no puffiness, no icterus. Child has a flat facies, mongoloid slant, short nose, open mouth. Clinodactyly is present. He is hypotonic, pointing towards the Down's phenotype. So, child was active, playful, lying comfortably on bed, hyperextended legs, pulse was 140 per minute, high volume, non-collapsing, regular pulse, all peripheral pulse is equally felt, no radioradial or radiofemoral delay, rate of respiration 30 per minute, abdominothoracic type of respiration, mild subcostal and intercostal contractions, blood pressure 92 by 36 millimeter of mercury in upper limb, and 100 by 46 millimeter of mercury in lower limb measured by oscillometric method. SpO2 was 97% in all 4 limbs. Coming to the cardiovascular examination, trachea is midline, chest wall is a hyperinflated chest wall, apex is in the fifth intercostal space, down and out 2 centimeter lateral to the mid-clavicular line, forceful, ill-sustained with medial retraction. A palpable second heart sound is present in the left intercostal space, palpable P2. Epigastric pulsations are present. Grade 1 left parasternal lift is present. Second left intercostal space is dull on percussion. The right heart border is retrosternal, left border corresponds to the apex.
Right. So, now on the auscultation, right?
S1 is normal, S2 is narrow, split, and loud. There was a harsh machinery quality of murmur 3/6, mixed frequency systolic murmur with late systolic peaking, associated with multiple flakes, best heard in the left second intercostal space and infraclavicular region, which increases with expiration. Also, grade 2/4 mid-diastolic rumbling murmur was present at the apex without any pre-systolic accentuation or opening snap. There were no other sounds.
Anything else you have the clinical examination?
So liver was 4 centimeter palpable below the subcostal margin. Spleen was not palpable. There was no corresponding bronchi.
So the chest was clear.
Yes.
Fine. So we'd like to, this is quite an elaborate examination. Can I go back to the first slide of the examination, please? First slide of the examination. When you have started the examination, can you come back to that? Yeah. You see, on this particular slide, you have said that all the three parameters, there is a weight, height, and the head circumference are less than the third percentile, which is obviously it points that there is gross failure to thrive, and there is also pallor. There was no sinus puffiness, and the child appears to be syndromic. Most probably, the child is resembling the Down's phenotype. Though we do not have a karyotype result at the moment, but obviously going by the phenotype, you have the Down syndrome phenotype, isn't it? So in this particular case, do you think that this particular history or this particular feature that the child has a Down syndrome with some sort of a post-tricuspid shunt on which we are working upon has some specific resemblance, specific importance in this case, or rather it can turn the history or the more total pathogenesis to slightly off track? I mean, the child having Down syndrome. Do you think that, as per your diagnosis, clinical diagnosis, the first clinical diagnosis we are working upon is a post-tricuspid shunt, moderate size post-tricuspid shunt? Do you think that this particular diagnosis is going to make a major shift to your pathophysiological process, or we can just let it off pass?
Usually, so Down syndrome, most common association of Down syndrome is with complete AV canal defect. With,
right. But it can be associated with anything. It can be associated with any other large shunts.
With tetralogy of Fallot.
Correct. So, in any particular pathogenetic importance of this Down syndrome in your particular case, like it will aggravate some pathological process, or it can.
Children of Down syndrome usually get early pulmonary vascular obstructive diseases due to various reasons.
Can you mention them? What are the various reasons? Why do they get severe pulmonary hypertension very early in life?
Mostly Down syndrome children have a structural pulmonary hypoplasia. They have alveolar hypoventilation. That is, the number of alveoli are less as compared to the normal kids of the same age group. Also, they have recurrent upper respiratory tract infections, which lead to due to the tongue fall, leading to obstructive sleep apnea. They have adenoid hyperplasia, tonsillar hyperplasia, which all lead to recurrent chest infections, aspirations, and recurrent pneumonia. Also, they are immunocompromised, which again lead to more recurrent respiratory tract infection, leading to early pulmonary vascular obstructive disease.
So these points which you have mentioned does really make a huge change in the pathogenesis, isn't it? The importance is that the child is already 2 years and 11 months. It's almost 3 years. So by this time, if the child has a Down phenotype, this child would have become severely pulmonary hypertension had it been a moderate to large shunt, isn't it? So that this particular finding in your case gives a totally different meaning. That means now that we have to make out that whether the child has severe pulmonary hypertension, or if not, then why has the child escaped? Was there any particular reason? And obviously by clinical diagnosis and obviously by taking help of other investigations, now we have to find out that whether the child if the child really has some pulmonary hypertension, whether it is still reversible or non-reversible, isn't it? So this is the specific importance of which I am going to ask you regarding the importance of Down syndrome in this particular child, where you have shown that there is failure to thrive, plus there are other symptoms. Can I go to the next slide, please?
Slides are not moving.
Slides are not moving. So you have it active playful. Active playful lying comfortably on bed with hyperextended legs. The child is slightly tachycardic at 3 years of age, 140 per minute, high volume, non-collapsing, regular, all previous pulses equal. So would you like to assign any particular importance to the high volume and non-collapsing? Since you have mentioned this one, high volume and non-collapsing, what do you mean with the high volume and non-collapsing? Or do you want some particular importance to be assigned to this point?
So high volume pulses basically is also reflected in the blood pressure, which is the white pulse pressure in this particular child. So, but it is non-collapsing. So, I can consider a large PDA or an EP window. But as it is a non-collapsing kind of pulse, usually high volume non-collapsing pulse with brisk upstroke is found in aortic regurgitation classically. But as it is a non-collapsing pulse, I would still go with a large PDA or a AP window.
Okay, so you have assigned some particular importance. It's a non-collapsing. You want to say that it is the differential diagnosis also include a large PDA and large AP window. Obviously, it's a moderate tricus, both tricus sham. It can easily include all these differential diagnoses included. It is an abdominal thoracic respiration. Your blood pressure mentioned the 92/36. Which is yes, it's almost in track with the age of about 3 years, and saturation is 97% in all 4 limbs. So from this page, from this particular slide, if I ask you what are the particular points in clinical history, clinical findings would you like to pick up, which will help you in pinpointing some important findings in the pathogenesis. Or that is what I mean to say is, suppose you are saying saturation of 97%, the BP of 92/36, there's a wide pulse pressure, plus there is a silent tachypnea at 30 per minute. So what are these points favor? What are these points favor in your diagnosis, in your particular diagnosis?
It is an acyanotic congenital heart disease with increased pulmonary blood flow, and child is in congestive heart failure.
So these are the good points which I mentioned, that the saturation is 97%. That means the child is not cyanotic. The blood pressure has a wide pulse pressure. That means the child is a hyperdynamic condition. Is in a hyperdynamic condition. Though you cannot rule out that whether it is a PDA or EP window or a VSD right from this stage. Had it been a PDA, we would have expected, or an EP window, we would have expected the diastolic pressure to be slightly low. The JVP, someone as Rahul has mentioned that this JVP, you haven't mentioned the particular JVP here. You have mentioned silent tachypnea with respirator 30 per minute, but there is no retractions as such. Pulse is 140. I think JVP you have mentioned in the next slide.
Go to the next slide. It's a Down syndrome. The child has it's a small child, short neck.
So you say that it's a small child with a short neck. So that means that is not allowing you to read the JVP properly. That is definitely one of the reasons. So, but obviously in a small child, can you name any condition where the JVP would have been much prominent even in a small child? Mostly in small children, the neck being very short and small area, we cannot interpret JVP except under some predisposing conditions. Like, for example, in a complete heart block. Then you will obviously have some Canon waves, and where the JVP, even if you are not particularly attentive, it will come across and you can see that it is a complete heart block also, isn't it? Go to the next one, please. Tracheus and midline, apex in the 5th intervascular space, down and out. Any particular point you wanted to make by mentioning this particular point, the 5th intervascular space? There is gross cardiomegaly and the palpable heart sound in the second left intervascular space. Epigastric pulsations and grade 1. So do you mean to say anything particularly here? Epigastric pulsations and grade 1 peritoneal lift?
There is an RV hypertrophy present.
RV hypertrophy. Okay.
RV overload.
RV volume overload, hypertrophy. Because hypertrophy would mean that there is some pressure in obstructive lesions, isn't it? Particularly. Fine. Go to the last slide. Rahul is mentioning some LV. Yes, Rahul, you can unmute yourself. You mean to say something? Kavita, you can allow Rahul to unmute. LV volume overload. You mean to say there is LV volume overload. Yes, definitely. All these clinical findings point out towards something called an LV volume, definitely. So on the auscultation front, what describe the auscultation, please?
S1 is normal, S2 is narrow split and loud. There is a harsh machinery 3/6 mixed frequency systolic murmur with late systolic peaking associated with multiple clicks best in the left second intercostal space and infraclavicular area, which increases with expiration. There is a 2/4 mid diastolic rumbling murmur at the apex without presystolic accentuation and opening snap.
No other sounds. Right. So from your auscultation, we have mentioned that this S2 is narrow split and loud, and there is a harsh machinery murmur 3/6 frequency, mixed frequency systolic murmur. So from these 2 points, S1 is normal, I believe. S1 is normal, and it is not. Your murmur is not adjacent to the S1. That means S1 is normal. That means your murmur, you can auscultate the S1 distinctly and separately. So you have described a harsh machinery mixed frequency systolic murmur. Obviously, so it is starting after some gap after the S1, if I am correct. So do you want to attach some particular importance to that particular point? That it's not a what particular point would come up here, that the S1 is normal and the harsh machinery murmur is mixed frequency with late systolic peaking. That means it is not pansystolic. So does this include or exclude some particular condition?
So basically, it's a mixed frequency. The character of the murmur is a mixed frequency murmur. It can occur both in a VSD and a PDA, but it is associated with multiple clicks, and the region, the area of auscultation is the infraclavicular area, which is pointing more towards the murmur of a PDA rather than a murmur of a VSD. However, in a PDA in which a diastolic equalization occurs, the murmur mimics as like of a VSD.
Okay, so from your auscultation, given the fact that whatever you have mentioned previously from your clinical examination, where we are working still on the first diagnosis, that it's a moderate size post-tricuspid shunt. So now we have narrowed down your diagnosis to say it is an acyanotic heart disease, moderate post-tricuspid shunt. Now, what are the differential diagnoses which will come into your mind before we go deep into the auscultation? Can you now just mention some of the congenital heart diseases which can come narrowed down with this kind of an auscultatory findings or this kind of a clinical findings? So, what are the things which you are playing around with now?
Sir, moderate size VSD, which is getting restricted, a moderate size PDA, or a small EP window.
Or a small EP window. Or small. You have used the word moderate or small EP window. Why do you say so? Why cannot it be large?
So large EP window would have been
the presentation would have been earlier.
Presentation would have been earlier, but and also by 3 years of age, a large AP window would have been would have had the features of a pulmonary vascular obstructive disease, especially in context of Down's facies.
Now, the pulmonary vascular obstructive disease, the word pulmonary vascular obstructive disease may not be used so freely as you are using. It is better to use the severe pulmonary hypertension, because the pulmonary vascular obstructive disease to pinpoint clinically is very difficult. Rather than that, you can use the word severe pulmonary hypertension, because as far as you know, the pulmonary vascular obstructive is almost a histopathological findings, isn't it? So you can use that the child would have, expected the child would have had severe pulmonary hypertension, and the auscultatory finding, clinical history, everything would have been slightly, and the clinical finding would have been slightly different. The S2 is narrow, split, and loud. Now, are there any particular conditions where the S2 can be narrow, split, and loud?
Sir, in a large post-tricuspid shunt with severe pulmonary hypertension, but which is still reversible, will present with a narrow split, and the S2 will be loud.
So which component of the S2 is loud here?
So P2 component.
The P2 component is loud as the A2. So it is narrow split plenty of number of times. It can become one single sound. That is, the A2 and P2 can merge. So what are the conditions where the A2 and the P2 can merge for forming one single sound?
Severe pulmonary artery hypertension.
That is precluding the pulmonary valve to close a little bit later when the A2 and P2 are merging. And since the A2 is already loud and the P2 is almost following the same, demeanor, then both of them can produce a single loud S2. So you have mentioned that the harsh machinery murmur. Why did you pick up the point to describe it as a harsh machinery murmur? Was there any particular reason?
So the
Are you thinking of some particular thing, and what is the reason, pathophysiological mechanism behind it?
The character of the murmur is a machinery murmur, which is a classical murmur of a PDA associated with multiple clicks, which are the eddy currents associated with it. And it is a mixed frequency murmur that has both the low frequency and the high frequency sound.
So it's a mixed frequency murmur. What are the other frequencies of murmurs do you know of?
So high frequency murmurs and low frequency murmurs. High frequency murmurs are blowing murmurs like aortic regurgitation, high pressure pulmonary regurgitation. And low frequency murmurs are murmurs which are present in cases like mitral stenosis.
Where would you place a murmur from a VSD or a mitral regurgitation? VSD or a mitral regurgitation murmur?
A mitral regurgitation murmur is a high frequency murmur. VSD murmur is a mixed frequency murmur.
Okay, so now that you have come down to this, boiled down to this diagnosis, the heart's machinery 3/6 frequency systolic murmur, best starting the left second intercostal space and infraclavicular area increases with expiration. That means you are slowly narrowing down your diagnosis to some particular point. And there is a 2/4 mid-diastolic rumbling murmur at the apex without pre-systolic excitation opening snap. Now that you have mentioned these two things, can you more describe what are your differential diagnoses narrowly gradually coming down to? Or maybe I'll allow you to summarize your clinical findings once more. You can go to the summary slide of your clinical findings. Thereafter, we can narrow down your diagnosis to something else. So the liver, yeah, you're showing some slide liver, the liver. Yeah, post-central palpable with the right subcostal margin. Spleen is not palpable, no crypts or wrong. Fine, go ahead please. Now can you summarize your clinical findings?
It's a 35-month female baby with hurried breathing, poor feeding, vomiting, 1 episode of hospitalization, 2.5 kg birth weight, failure to thrive, tachycardia, ROS2 symptoms, high volume pulses, hyperdynamic LV type of epics, grade 1, left parasternal lift with epigastric pulsations. It's not a single loud S2, it's a loud S2 with narrow split, 3/6 harsh systolic murmur at infraclavicular area, multiple clicks, mid-diastolic murmur at apex, enlarged liver in congestive heart failure, Down's phenotype with moderate developmental delay.
Okay, so a large and good summary. So this is a 35-year-old female, hurried breathing, so the child is still symptomatic. Had only 1 episode of hospitalization, though the birth weight is 2.5 and the present weight 9.8. So in 3 years, we will say that it's gross failure to thrive with tachycardia, ROS2 symptoms, and high volume pulses. They are not non-collapsing, hyperdynamic LV apex, and there's some parasternal lift. So now can you come down, narrow down your diagnosis to something?
So my final diagnosis is the situs solidus levocardia acyanotic congenital heart disease with a moderate size post-tricuspid patient, most likely PDA, increased pulmonary blood flow in congestive heart failure, severe hyperkinetic pulmonary artery hypertension in sinus rhythm, no evidence of infective endocarditis in a phenotypically Down syndrome baby with moderate developmental delay.
Fine. So you said it's a moderate size post-tricuspid, most likely a PDA. Yeah, Rahul wants to know the multiple clicks and significance. Yes, definitely, Rahul. We'll come to that point. So, there's a moderate size post-tricuspid, most likely. Why do you zero in the PDA? What are the points in favor and what are the points against?
See, it's a post-tricuspid patient.
Why do you zero in on the diagnosis of PDA? Can it be a VSD? Can it be an EP window? Or can it be anything else? You have to give you rational findings.
So it can be a VSD, just the location of the murmur and the quality of the murmur is
fine. What are the differential diagnosis of a difference between the location of a murmur classical VSD and the location of a murmur of a PDA?
Location of the murmur on the VSD is third or fourth parasternal, left parasternal area, and PDA murmur is best heard in the second left intercostal space or the pulmonary area or the infraclavicular region.
Definitely. The next question you invite is, can it be, what will happen to the murmur if it's a subpulmonary VSD or an outlet VSD?
So outlet VSD murmur will also radiate towards the infraclavicular area, but it is not associated with the pulmonary stenosis murmur is majorly an ejection systolic murmur as compared to the murmur.
So VSD murmur, the quality of the, you mentioned the quality of the murmur as well, isn't it? The quality of the murmur and the particular type of the murmur. The VSD murmur being the difference of pressure between the LV and the RV. If it is a moderate sinusoid, it is a restrictive one. So how do you expect the murmur to be? It's a pansystolic murmur. It's a pansystolic murmur. So the murmur starts with the S1. So the S1 would not be distinctly audible because the S1, the quality of the S1 will be slightly hampered. The murmur will start with S1, cross over through the S2 and spill over into the diastole, if not carried over the whole length of the diastole, isn't it? So it's a pansystolic murmur. Specifically, if it is an outlet VSD, the murmur, classically perineumous VSDs or a subaortic VSD, you find the murmur to be more towards the left duodenal border, preferably in the left fourth space or maybe in the surrounding region. Sometimes it may be conducted to the other parts. If it's an outlet VSD, the murmur will be more prominent and moving towards the second upper intercostal space. And obviously, but the way to differentiate from a PDA murmur is, it will be the PDA murmur is more or less will be a continuous one, whereas the VSD murmur will be a more or less a pansystolic murmur. So sometimes the VSD murmur will spill just over the S2 as well, isn't it? So the PDA murmur, now that you have got a PDA murmur, there has been some questions, the eddy currents and the eddy currents, what are the importance of the eddy currents won't be there in outlet field. Yeah, Pratibha, you are right. The eddy currents won't be there in the outlet VSD. Now, what are the causes of these eddy currents? What are the particular pathophysiology for this eddy current? These are flows within flows. That is, the major flow which is moving towards the pulmonary artery or this thing. There is some turbulences, local turbulences. So the difference of pressure between the aorta and the pulmonary artery, whenever like just like a waterfall, whenever the waterfall comes out from this water drops in from a high pressure zone to a low pressure zone, they form local currents which are seen in any water flow corrector. So that is the reason, especially whenever there is a pulmonary artery is dilated, there might be eddy currents which produce this kind of a multiple valvular click-like sounds, which gives a characteristic machinery murmur to the PDA murmur. Right. So definitely there won't be any eddy currents in the outlet VSD because the pathophysiology of the murmur is slightly different. So can you stick on to your last slide, please? Don't take up the last slide. Yeah.
It is going.
Yeah, most likely PD. So you say there is an increased pulmonary blood flow, and the child is obviously there is an increased pulmonary blood flow situation. Now can you tell what are the clinical features you found that you have mentioned there is increased pulmonary blood flow, specifically at the age of 3 years in a clinically phenotypically Down syndrome patient?
Child, according to the symptoms, child is having hurried breathing and subcostal and intercostal retractions till now, and
also the child is not gaining weight. So that is one of the clinical features why you might say that the child still has features of increased pulmonary blood flow, and obviously the child is in congestive cardiac failure. What are the points in favor that you made the diagnosis the child is having congestive cardiac failure? It is compensated. Is it compensated or uncompensated?
Child is in a compensated cardiac failure.
In a compensated cardiac failure. Otherwise, the child would have been much more distressed. The child wouldn't have moved out without an oxygen, would have needed some respiratory support, or the child would have been there was gross tachypnea or retractions, isn't it? So the child is making up somehow for his cardiac failure. There is severe hyperkinetic pulmonary hypertension. Now, what are the different kinds of pulmonary hypertension you come across in clinical medicine? What are the different kinds? You have said severe hyperkinetic pulmonary hypertension. So what is the
reversible pulmonary hypertension or irreversible pulmonary hypertension?
Fine. So one is a reversible and one is reversible. So how can you make it out, differentiate them clinically?
So clinically, first of all, child is saturation is 97%.
Fine. Does that give you a very valuable clue?
Is having features of increased pulmonary blood flow, still having intercostal, subcostal retractions present, having failure to thrive. There is a mid-diastolic murmur which is present in the apex, which is a flow murmur across the mitral valve. So that also points towards an increased pulmonary blood flow.
Fine. Also, now there is one apparent paradox. Yeah, there's one apparent paradox. You didn't find a continuous murmur. You have said because there is a systolic murmur which has a machinery character. Now, how do you tally this one with a severe hyperkinetic pulmonary hypertension with the other one? That is you were saying that it's not a continuous murmur. Does they go hand in hand, or would you like to elaborate some other points on that one?
So there is definitely there is diastolic equalization in a PDA now, which is going towards the pulmonary artery hypertension, but still it is reversible because the mid diastolic murmur is present, child is acyanotic yet, and a continuous murmur might be absent in a PDA in reasons like if the PDA is small or if the PDA is very large, then also we do not find the diastolic component of the murmur. Also, the diastolic component might be very small, which is not heard in this kind of tachycardia. Had it been less, I could have appreciated, but I'm sure that there was not a diastolic component present.
Fine. So the diastolic component being absent from this continuous murmur, where you are making a PDA, points out to the fact that definitely there is a diastolic equalization. So now, if in a PDA, pathophysiology PDA, if there is obviously flow-related pulmonary hypertension, the first and foremost pressure to be equalized is the diastolic pressure. But obviously later on, when the systolic pressure equalization is there, obviously you will get either you don't get a murmur or you get a very faint systolic murmur to begin with, because at some phase of the cardiac cycle, the aortic pressure might still be slightly higher than the pulmonary pressure. Now, Rahul is written, it is hyperemetic pH. PA diastolic pressures should be low as compared to aorta. So diastolic murmur should be heard. Obviously, the diastolic murmur is not heard in this case because the diastolic equalization is there, and that is the reason we are not hearing the diastolic murmur. That much I would agree. But obviously, the systolic and during the systole, there is still a difference between the aortic and the pulmonary pressure. That is the reason the murmur is limited itself to the systolic period only. You are right in that case. So, increased pulmonary blood flow, still there is some increased pulmonary blood flow situation in congestive heart failure. If you are hypertensive pulmonary and the child is having some cardiomegaly. In sinus rhythm, no evidence of infective endocarditis, phenotypic Down syndrome, and moderate development delay. So the question which I asked you at the very onset, that this moderate development delay, would you likely to ascribe the whole thing to the congenital cardiac condition, or there may be something else? Yes, definitely. The fact that the child has Down syndrome, at least phenotypically, do not know the karyotype as well, that is also hampering the growth and development of the child to some extent. Now, let us come to the conclusion. Would you like to show us the investigations? How do you go in for the investigations of this child? You don't have the investigations along with you. Okay, fine. No problem. How would you like to investigate this child? To come to your conclusive diagnosis, what you would like to investigate? This is a clinical diagnosis.
After that, I would like to see the X-ray. The ECG both the ECG and the X-ray would help me. Child is having cardiomegaly, increased pulmonary.
Traditionally, in a cyanotic heart disease, you would look for the ECG, and for the cyanotic heart disease, you look more for the X-ray. It's not that we cannot interchange; we can definitely interchange. But classically, there are more X-ray changes on the non-cyanotic disease. And is it time up, Kavita? Kavita, is it time up?
So can continue.
Okay, fine. So you think that this is a moderate development delay? I mean, anyway, what are the aspects of clinical diagnosis in the X-ray? What are the features you are expecting on an X-ray with reference to this particular child? What are the points in favor that will leave with the diagnosis the child is still reversible?
There would be an increased pulmonary plethora would be present. There would be cardiomegaly and dilated pulmonary artery.
Right, dilated branch pulmonary arteries is actually a double-edged sword, because you can say the dilated branch pulmonary arteries will definitely give you an idea that this is hyperkinetic pH. But obviously, if you get a cutoff sign at the 1/3, 2/3 junction, and definitely you can say that the child has some amount of pulmonary vascular obstructive disease already developing. But together with that one, Yours, the child will be slightly cyanose, the saturation should be less than 90%, and obviously the heart won't be enlarged that much. There are some overlapping regions where the child might be still in a reversible stage. What are the expectations on an ECG? If you take a 12-lead ECG of this child, what are the expectations? What can you have? You have already mentioned the child has a situs solidus levocardia. So what are the expectations from the ECG of this child, whom you are thinking it's a moderate size post-tricuspid shunt, the last most likely a PDA?
So there would be in left axis deviation, LV forces would be more prominent. There would be Q waves which would be present in the V5, V6 region. LV would be volume overloaded. That is they would be the normal RS progression. The S wave would be deeper in V1 and R wave would be taller in the V5, V6.
Okay, so these are the features which will still tell you that probably there is left ventricular dominance. What if I say that the V1 and the V2 are showing that there is the QRS complex, or rather the R wave is more prominent in this particular child in V1 and V2. So what, rather than in V5 and V6, and in V5 and V6 you get deep S waves compared to the V1 and V2. So what would that particular point imply?
There would be more of the RV forces in this child pointing to.
And plus, along with the fact that there is absence of Q waves in the left lateral leads, as the D4, 5, 6, that means there is some amount of pulmonary hypertension developing. And on this clinical basis, together with the drop in saturations, the heart shrunk on the X-ray, these are the features where you can find that probably the child is not having a hyperkinetic pH still, and the child might, and the child might pass on into an irreversible stage, isn't it? Fine. Yes, Rahul, we are trying to answer the question. Is this patient operable clinically? So clinically, what are the features? We have already discussed some of the features. If there is cardiomegaly on X-ray, there are still features of increased pulmonary blood flow if the saturation is more than, say, 95%, and the child is having Q waves on the left side of the leads, chest leads, and obviously there is left axis deviation. So these are the features which will help you to differentiate that probably the child is still reversible, because particularly in Down syndrome children, according to the norms, we usually operate on large left-right shunt lesions, especially in Down syndrome babies before the age of 6 months, because these people are more likely to develop pulmonary hypertension from large left-right shunt lesions than the general population, isn't it? So these are the features which will help you differentiate that this can. So apart from the X-ray and ECG, suppose this child has a saturation of, say, 92%, and the X-ray shows the heart is slightly small, and the ECG features are not that totally as we were describing. What would be the next step in the investigating of this particular child? What would you like to do now?
So I would like to go for a cardiac catheterization.
Cardiac cath and oximetry. You have to answer the full cardiac cath and oximetry. So in a cardiac cath and oximetry, can you elaborate what are the things you are going to look for? What particular values you are going to look for? Would you like to go for some resistance indices, or some particular pressures would you like to go for?
Pulmonary vascular resistance should be less than 4,
so preferably. Preferable current norms. So,
but in a PD, objectively,
so far it is a subjective one. So what are the objective criteria of stating someone irreversible? Someone to have an irreversible pulmonary hypertension, what are the objective criteria we should have?
Pulmonary vascular resistance more than 6 Wood units, a resistance ratio more than 0.33.
No, it's the PVR, resistance ratio should be more than 0.33. There is a SVRI, PVRI by SVRI?
0.7%.
0.33 is operable, no? 0.33 is operable.
0.73.
But latest guidelines are, I think, more than 0.5, you should be very, very cautious.
0.7.
More than 0.5, you should be very, very cautious. More than 0.75 is almost irreversible. And more than 0.5, you should be extremely cautious. And if the pulmonary vascular units, resistance units are more than 6 Wood units, absolute, then there is a contraindication that the child should not be operated. Or if at all, under some circumstances, pressing circumstances, you are operating, then some amount of residual shunt is, you should be keeping some amount of residual shunt. Either you will be keeping a large PFO, or there has been instances in some centers where even large VSDs have been closed, but leaving aside a part of the VSD. So these are the points where, so development, coming to the conclusion that this child has a situs solidus levocardia, most probably it's an ascending congenital heart disease, which you have rightly mentioned. Moderate size post-tricuspid shunt, most likely PDA, increased pulmonary blood flow in CCF, but it's controlled, and severe hyperkinetic pulmonary hypertension in sinus rhythm. So this pulmonary arterial hypertension has not become a fixed hypertension as of now. No evidence of IE and phenotypic downs and moderate developmental delay. So now, suppose the child's parents come to you and say that, doctor, I want to, if my child is operable, and if we operate on the child, so how do you counsel the parents that what are you expecting realistic, what should be your realistic expectations, and what should not be a realistic expectation? Because this counseling is of absolutely important, because the parents, what happens is in any syndromic parents, say in any parents of a syndromic child, obviously they are operated, the parents would think that the surgery will not only cure the cardiac disease, but at the same time it might cure the whole syndromic appearance. So how do you like to counsel these parents?
I would like to tell them that this is a large PDA or a moderate size PDA. It requires closure first of all, and it would the growth of the child would be better after the closure of the PDA, but it would still be less than the normal children because it's a syndromic child. The child suffers from Down syndrome, but the conditions of recurrent respiratory tract infection and failure to thrive would decrease to some extent. Also, it is required as to prevent the Eisenmengerization at later age, but we'll have to tell them that this would not cure the mental condition of the child. So we'll have to live with it.
Yes, you can look at it in two ways. One is the quality of life and the quantity of life. The quality of life wise, obviously, the correction of the cardiac problem will definitely increase the quality of life, because children with Down syndrome, though they may have some retardation of growth and the retardation in their developmental milestones, but obviously, if a large left-right shunt lesion is associated with that one, whatever benefit they would like to have from their life, that would also be hampered. That is the reason, always to increase the quality of life, we should operate on these children in time so that their quality of life is slightly improved. Coming to the fact that whether the parents can expect that this this operation will increase the quantity of life, that is, expand the longevity of the child. Obviously, there has been no specific evidence like that, whether there will be evidence of longevity will be increased straight away. But obviously, if the child, suppose this child is Eisenmengerized from a large left-right shunt lesion, that will definitely decimate the normal lifespan we would have expected. Normally, Down syndrome people live up to the age in the third or fourth decade of life. Thereafter, there has been instances there where they have been living well beyond the fifth decade of life. But if we have a child with Down syndrome and Eisenmengerization with severe pulmonary hypertension, not only the quality of life will be hampered, but to some extent the length of life might also be decimated. So, right, Kavita, are we in time? Hello, Kavita.
Recording stopped.
Yes, doctor. Yes, doctor.